Hello, good evening, everyone. So I hope you all are settled for today's wonderful academic activity. So today we have brought in one topic, that is women and diabetes. As we know that all of us do face the challenge in treating the diabetes in the ladies and women, and diabetes is increasing everywhere, and every person, including every gender, is equally affected. But there are some challenges while treating a lady or a girl or a woman with diabetes. So what are the differences? How should we be a little bit more aware about those things? Everyone should be able to understand that, and that will help us managing the treatment better, achieving the better glycemic control, avoiding the complication. Now, while treating a diabetes in a lady, it is a little different from gentleman or any person, because if she has not completed family, so obviously she has to go through the phase of the pregnancy and post-pregnancy period, and then of course the long-term avoidance of the complication. So the challenges are much more compared to any male gender in the ladies. So we have to be aware about those challenges while treating diabetes in the ladies and women. So for that discussion today, we have four learned, experienced, and beautiful ladies with us. All four colleagues are of mine. And we have Dr. Neelam Pandey, who is endocrinologist, senior endocrinologist in Gurgaon and NCR, Delhi. And Dr. Neelam Pandey is senior consultant endocrinologist currently at Pinnacle Super Specialty, Gurgaon. And she has with us the Kedarnath Gold Medal for Best PG Student and A.V. Gandhi Award for Excellence in Endocrinology 2016, and 8 publication. And she is invited for as a speaker at multiple forums. Beyond that, she has a huge experience of managing all the different aspects of the diabetes and all endocrine disorder. The next speaker with us today is Dr. Harmandeep Kaur Gill. Dr. Harmandeep Kaur Gill is a senior endocrinologist at MEDANTA, the Medicity. She is a colleague of mine for last approximately 10 years. She has done her DM endocrinology from prestigious SGPGI, Sanjay Gandhi PGI, Lucknow. And she has a huge experience of managing all sort of the endocrine disorder. And previously, she has worked as associate professor in Department of Endocrinology at UCMS Delhi, and her area of interest are PCO, adrenal disorder, osteoporosis, and of course, the diabetes and the other all general endocrine disorders. We have next speaker with us, Dr. Parjeet Kaur. Dr. Parjeet Kaur is also a very senior endocrinologist, currently now associate director in Division of Endocrinology and Diabetes at Medanta, the Medicity. Dr. Parjeet is also the DM from same stable All India Institute of Medical Sciences, and she is MD from Maulana Azad Medical College, New Delhi, and she has also won the 6th A.V. Gandhi Award in Excellence in Endocrinology and MMS Ahuja Award for Best DM in Endocrinology in 2011. Actively involved in research in endocrinology, more than 50 published paper in various journals, and her area of interest type 1 diabetes, hyperparathyroidism, osteoporosis, and she is also invited to multiple forum for as a speaker. And our next and final, last but not presenter is Dr. Amy Grewal, and Dr. Amy Grewal is another colleague from All India Institute of Medical Science. And I'm fortunate that we worked together for some time in All India Institute of Medical Sciences. She is currently the principal consultant in endocrinology, Max Hospital, Mohali. She has also received the A.B. Gandhi Award for Best Research Work in the field of the endocrinology and MMS Ahuja Gold Medal for being the best candidate in DM endocrinology. More than 50 published paper in peer-reviewed journal, and also invited at multiple forum for as a speaker nationally and internationally. So before I request Dr. Neelam to start presentation, a few words from the organizing secretary, Dr. Rujul Jain. Dr. Rujul, you want to add anything? Then we can go ahead with the presentation. Yeah, thank you.
Good evening, all the respected colleagues. It is indeed a pleasure for me to invite all the respected speakers for a special topic, that is women endocrinology. And sir has already given the background of the today's talk. So I invite Neelam Pandey ma'am for her talk.
So good evening once again. Sorry, my mic was muted. Um, the first talk is on diabetes in women, risk and complication. So as we know that diabetes is increasing terribly in all over the place, and as Sarah just said, it is increasing in all the age group and both the genders. But more than 50% diabetic population is female, and the prevalence of diabetes mellitus is indirectly correlated with increasing age of the population, and it is seen in higher prevalence in urban population than rural. This is a map which is showing diabetes. It was an epidemiological survey of diabetic population among female in the reproductive age group of 35 to 49. It was done in 16 states and union territories, and it was witnessed that all these darkened areas, which is especially in the southern part, Kerala, Tamil Nadu, Andhra Pradesh, and Mizoram, they had higher prevalence of diabetes, including Delhi, and lesser prevalence of diabetes in the central India. And number of women with diabetes is 10% higher than men, and similarly impaired glucose tolerance is also 20% higher than in men. And WHO reports 55% of the diabetic deaths occur in women. And diabetes is also the 9th leading cause of death in women globally and second in South Asian women. So we know the common risk factors of type 2 diabetes is pre-diabetes, overweight, increasing age above 45, family history of diabetes, sedentary life, gestational diabetes, or large size baby, or up to 8 kilo or 9 pounds, ethnicity, and if there is history of increased non-alcoholic fatty liver disease, then also there is increased inherent risk of acquiring type 2 diabetes. And type 2 diabetes, as we know, is a heterogeneous disorder with a common interplay of genetic factors along with environmental and lifestyle related factors leading to, such as obesity, inactivity, and stress, as well as increasing age. So we have divided risk factors of type 2 diabetes in women as biological risk factor, which comprises of BMI, body fat distribution, brown adipose tissue, metabolic syndrome, adipokines, few new biomarkers which are specific for female diabetes or female onset, and imbalance of sex hormones, pre-diabetes, and gestational diabetes mellitus. Then there are a group of psychosocial risk factors, which is socioeconomic status, psychosocial stress, sleep deprivation, and increased work stress, and health behavior, which is also very essential. Lifestyle behaviors such as sedentary or increased screen time, consumption of high-calorie meals or sweetened beverages, and increasing precedence of alcohol and smoking in female population, which smoking itself leads to increase in the relative risk of MI 25% higher in female as compared to male. So first and foremost is obesity and diabetes. Women with type 2 diabetes have higher weight and hip ratio, and they are more obese than men with type 2 diabetes. And sex disparities is due to difference in fat storage patterns in the adipose tissue in both women and men. Men have more fat-free muscle mass. Men have more fat-free muscle mass than women. So BMI not an accurate measure of the body fat mass. And men have greater visceral fat deposition and ectopic fat than pre-menopausal female, regardless of BMI or total body fat. Women also have greater body fat percentage and develop peripheral adiposity, where men gain fat majorly centrally. So 1/3 of the overweight women finally develop android phenotype. And this is a table which is showing the main sex dimorphism in body composition of premenopausal women with age-matched men. So male predominant metabolic trait is that during exercise, they have increased glucose oxidation, vis-a-vis it is non-esterified fatty acid oxidation during exercise in females. And they have NEFA storage at rest, while males have non-esterified fatty oxidation at rest. And they have increased skeletal muscle mass, and they have poor skeletal mass, leading to increase in insulin resistance, increased visceral adiposity, and increased ectopic fat, while the female have more peripheral subcutaneous fat and total body mass. And there is more prevalence of fasting plasma glucose, and there is increased 2-hour plasma glucose OGTT seen in females. So abdominal visceral fat is more strongly associated with insulin resistance in women than in men. And it is a stronger link between excess visceral fat and diabetes in women than in men. There is greater risk of MI with higher waist circumference and waist to hip ratio in women than men. And obesity and metabolic dysfunction in women decreases the inherent protection from cardiovascular disease by sex hormones. So postmenopausal women are more prone to male type obesity and lipid characteristics. And 40% of the male and 70% of the women with type 2 diabetes have abdominal obesity, indicating a strong link between type 2 diabetes and abdominal obesity, especially in female gender. And this is showing that from the same thing, that from normal glucose metabolism, when we progress towards impaired glucose and finally reaching the diagnosis of type 2, from normal to becoming type 2 diabetes, there is a constant increase in weight. Women are more likely than men to store fat subcutaneously, which is peripheral subcutaneous fat pattern, which we just saw in the previous table. And women need to gain more weight than men to reach the same level of abdominal visceral fat. And the women have a stronger association of abdominal visceral fat with insulin resistance than men. So their visceral fat is more metabolically active and increases the risk of insulin resistance and finally leading to type 2 diabetes. And they possibly have more adverse cardiometabolic consequences of abdominal fat than men. And women also have increased relative risk of diabetes associated CVD than men. So because of this trait, there is more chances of having diabetes in women, and which is to be attended more seriously. Then another risk factor is brown adipose tissue. The mass and activity of brown adipose tissue impact the energy metabolism and insulin resistance and type 2 diabetes. Women inherently have higher mass and activity of brown adipose tissue, and this is larger the amount and stronger the bad impact, it reduces the risk of diabetes in women, and estrogen has a positive impact on brown adipose tissue. The presence of this tissue decreases with age in both sexes, but with increasing visceral fat in female, this decreases further. So this again increases the risk in female obese patients. Then adipokines, we know that leptin and adiponectin and various other adipokines have important role in insulin resistance. And there's an inverse relationship between plasma adiponectin and insulin sensitivity, which is prominent in type 2 diabetes women. And this androgen decreases the adiponectin secretion. So postmenopausal, when testosterone androgens increases, this adiponectin level reduces and chances of diabetes increases further. Then metabolic syndrome, which is a combination of risk factor for CVD, including insulin resistance, hypertension, dyslipidemia, abdominal obesity. And this is increasingly, metabolic syndrome is more common in women than men. And it is also driven by increasing abdominal obesity and other cardiovascular risk factors in women. And postmenopausal increase in metabolic syndrome shows a greater androgenic lipid profile and hypertension. Then there are some novel biomarkers which are especially related to causing diabetes in related to type 2 diabetes only in women, which is fetuin A, copeptin, proneurotensin, and even low vitamin D level. In one of the study associated with onset of type 2 diabetes, it is more related with type 2 diabetes associated in female than males, and the level in that particular study was 15 nanogram per ml. And premenopausal female have lower enzyme levels and less liver fat and BMI than age-matched men attributable to their estrogen level. Then role of imbalance of sex hormones. So we know that estrogen and androgen regulate the bidirectional control of glucose and lipid homeostasis and their receptor activation both sexes. Diabetes is linked with higher testosterone levels in women, but lower testosterone level in males. So if testosterone levels are increased in female, there are more risk of having diabetes. And that is why postmenopausal female and PCOD girls have added risk of having diabetes. PCOS show androgen excess and hyperinsulinemia associated with obesity, type 2 diabetes, and higher cardiometabolic risk. And 45%, approx up to 45% of PCOS will develop type 2 diabetes or have impaired GTT. Type 2 diabetes women also, on contrary, have 5 to 10 times risk of developing PCOS, and they have an 11-fold risk of metabolic syndrome with dyslipidemia. And gestational diabetes is another strong risk factor for onset and progression of type 2 diabetes. GDM predominantly affect insulin resistance in overweight obese women with increased age at conception. However, normal weight women may also be impacted due to genetic and physiologically exaggerated insulin resistance during pregnancy. And gestational diabetes, women have 70% greater risk to develop type 2 diabetes than women with pre-diabetes of developing type 2 diabetes. So any potential sex difference in the assessment of monitoring of vascular risk factors or difference in initiation of lifestyle or pharmacological intervention may result in less optimal treatment, inadequate risk factor control, and consequently more severe clinical outcomes. So difference, the gender disparity can happen at 3 healthcare provision level, which is first is evaluation and monitoring of risk factor. So there's often delay in the diagnosis. First, the diagnosis is delayed. Then monitoring of risk factor is not done adequately or optimally. Then control of risk factor among those. So once it is identified, then also the macrovascular complications are not attended well. And then at the level of pharmacological and lifestyle intervention, that inadequate treatment, inadequate follow-up, and sometimes initially they are active, but sometimes under psychosocial pressure, they stop following and sometimes even leave the treatment. So difference in drug adherence, which can bring adverse cardiovascular outcome and premature mortality. And a meta-analysis of 53 trials have shown that 50% men and 47% women were adherent to statin, and their response to statin was also variable. And apart from this, the very important aspect in women with diabetes management is difference in socio-culture aspect. The gender disparity affect illness manifestation, treatment-seeking behavior, and nature of treatment, and the care and support of family and caregivers. Owing to various reasons, poor literacy, early marriages, no financial independence, domestic duties, cultural barriers, keeping family priorities over their own health, denial, and social stigma. So apart from this, all these factors lead to increase in insulin resistance, and this in women with obesity, insulin resistance, and compensatory hyperinsulinemia, which precede the development of type 2 diabetes, also increases the risk of cardiovascular disease. So sex-specific genes influential prenatal growth and future development of insulin resistance may be responsible for small size of female neonates as compared to the male counterparts. And family history also increases the risk of insulin resistance by 2 to 3 times. And in women with history of diabetes on the maternal side is more related to diabetes onset in female, whereas in men, both maternal as well as paternal side contribute equally to the risk. So if type 2 diabetes, now we see if at least one parent will have diabetes, that is what we clinically see. And if both the parents have diabetes, there's increased 40 to 50% risk of having diabetes. Lifestyle, physical inactivity, and high calorie intake remain important contributors to increase insulin resistance. And relative risk of diabetes onset this is one of the European study in which relative risk of diabetes onset was 2 for lean women with physical inactivity against 10.7 for risk for active and obese women, and further increase in the relative risk of 16.7 in active and obese women. So obesity still is a stronger risk factor, type 2 diabetes, along with inactivity, but obesity still outpowers the sedentary behavior. And television time is also a strong predictor of metabolic syndrome. Higher the number, increase relative risk of having metabolic syndrome and further diabetes. And eating irregularly time, if that correction was done, there was reduction in the risk of diabetes by metabolic risk by 60 to 70%. Apart from this, is insulin sensitivity in perimenopause phase. Perimenopausal female differs from the age-matched men. During menopause, there are certain metabolic changes which contribute to rapid rise in CVD. There is higher bioavailable testosterone and lower SHBG, and this contributes to rise in risk of insulin resistance and metabolic syndrome. And as per SWAN study, the odd of developing metabolic syndrome per year was higher in perimenopausal than postmenopausal female. And increased plasma insulin and HOMA-IR levels suggest an impairment of insulin homeostasis during perimenopausal period. Women and complication of diabetes. So we know that since there is a regional prevalence of diabetes and it is constantly rising, there is increased burden, added burden of insulin resistance right from in utero to puberty, and then predisposes women to long-term poor health from younger age. And women of reproductive age with diabetes also affect the health of future generation when they have gestational diabetes or pre-gestational diabetes. So it becomes a unique challenge to manage this adequately so as to protect her and her future generation. Common perception is that female gender is protected from the long-term complications, so care is suboptimal. Gender discrimination is faced by women with diabetes across South India, especially in access to health services and support, as we just discussed, which leads to higher rise in rates of morbidity and mortality, especially cardiovascular. So this is one of the this is a forest plot of one of the meta-analysis of sex differences in the effects of diabetes on cardiovascular outcome and cancer, expressed as women to men ratio of relative risk and additional risk. So here we can see all the cardiovascular outcomes such as coronary heart disease, stroke, dementia, vascular dementia. There is increased additional risk in women as compared to men, 182% as compared to 116% for coronary heart disease, and relative risk of 1.4. And similarly for stroke, it is 128 versus 83% in men, and there is relative risk increase of 1.27. So subsequently, similarly for CKD and for a few cancers. So we can see that cardiovascular outcome is definitely at the cardiovascular health is definitely at additional risk in female group. And though the focus is more on type 2 diabetes today, but this is one forest plot which is showing, which was published in Lancet. It was a systematic review and meta-analysis of approx 50 studies of type 1 diabetes, which showed that there's a roughly 40% greater risk of all-cause mortality and twice the risk of fatal and non-fatal vascular events when compared to men, which is seen in female with type 1 diabetes. So there are a battery of complications. Sometimes patient straight away land with decay, and there's a list of acute complications. Diabetic ketoacidosis is highest in adolescent and younger females, and this is definitely more common, but sometimes seen in poorly controlled type 2 diabetes also. Periodontal infections, genital infections, other secondary infections are seen in poorly controlled diabetes, and often seen in onset of at the time of onset of puberty in children with type 1 diabetes. Psychosocial issues in children and young adults can lead to poor drug compliance and morbidity. And younger girls, especially type 1 and young adults, they have often seen to have eating disorders, anorexia nervosa and bulimia. These group of patients, especially females of all across the, all group of patients, young or old or middle-aged, are depressed and anxious, but when it is diagnosed for the first time, they are extremely depressed about this chronic disorder, and it is very common in adolescent and young female, more in type 1 because they have to take insulin. Higher prevalence of anxiety in diabetic women than men, 20 versus 11%, and similarly for depression. And chronic complications can be grouped into micro and macro. So microvascular complication, diabetic retinopathy, it is more in female type 1 diabetic patients, but it is more severe in male. Though there is no gender difference in type 2 diabetes patient, but it is independent predictor of cardiovascular mortality. Non-proliferative diabetic retinopathy has been strongly associated with CV mortality in diabetic women. And diabetic nephropathy, from microalbuminuria to overt proteinuria to renal insufficiency or in combination, can be witnessed during the course of the diabetes. And faster progression of diabetic nephropathy is seen in men, but more males on dialysis therapy and with kidney transplantations. But females have higher risk of proteinuria and subsequent renal disorder. Leading cause of ESRD requiring dialysis is diabetic nephropathy and associated with increased CV mortality. Diabetic neuropathy is seen in female, but it is more common in male. Cardiovascular complication, this is 40% higher seen in females. There is increased risk. Ischemic heart disease differ between men and women according to the presenting symptom, their way of diagnosis and evaluation and prognosis. All are very different than the male counterpart. There is increased CV mortality in diabetic women due to several reasons. It is less aggressively treated, have more combined CV risk factors in men, and it is more severe and have worse impact in women than in men. And the diabetes mellitus abolishes the protective estrogen-related benefit on CHD in normal women, and once the diabetes appear. And diabetic women should be treated as aggressively as men in occurrence of an acute coronary event. Other CV risk associated with it is diabetic dyslipidemia. They have low HDL, high triglyceride, and increased small LDL particle, more marked in diabetic women than men, and have more severe impact as a CV risk factor. And low HDL increases fourfold risk of CHD. Statin use do not have the similar beneficial effect in female as compared to male. And hypertension is more frequent and deleterious in female. 10 mm rise of SBP leads to 30% increase in CHD mortality in female compared to lesser in male. Obesity and elevated BMI is more strongly associated with LVH and heart failure and other impaired cardiovascular risk factors. Add to adverse CV outcomes in men than inactivity in women. So BMI and abdominal obesity is a stronger marker for adverse cardiovascular outcome than only sedentary life. Metabolic syndrome also adds to the CV morbidity and mortality, and there is increased coronary calcification, inflammation, oxidative stress, and endometrial dysfunction associated with worse outcome in obese type 2 female. And they have more prothrombotic status owing to partly due to inflammation related endothelial function and higher coagulable status. There is increased activation of RAS and mineralocorticoid aldosterone, which is also progesterone sensitive. So they have a higher thrombotic status. Apart from this, increased risk of 27% greater in risk of stroke, and both fatal and non-fatal seen in female. Foot complications more seen in male, but they are often seen in female also. And women show higher mortality related to amputations. Osteoporosis, type 1 BMD decline, and there is from 6.4 to 12.4, 2.5 fold increase of fracture, whereas increase of fracture was observed in type 2 diabetes despite higher BMD. And pioglitazone use in old type 2 diabetes women increases bone loss, so should be avoided. Menstrual irregularities, PCOD is seen in type 2 phenotype females, type 2 diabetes females, but 20% of the type 1 diabetes also have menstrual irregularity, which is having PCOS phenotype. So that should also be adequately treated. Sexual dysfunction seen in 50% of the female diabetes patients who have sexual dysfunction, dyspareunia, vaginal dryness, candidiasis, and other secondary issues. Comorbidities and physical limitation, this burden is higher in female as compared to male, and the cognitive limitation, higher risk of cognitive impairment, depression, falls is also witnessed higher in female. Pregnancy complications, this is very important because not only the affected patient, the future generations also affected. So higher risk of the various complications which maternal and fetal both can be seen if it is not adequately attended, higher risk for primary cesarean section, preeclampsia, premature delivery, stillbirth, perinatal mortality, and poor fetal outcomes such as diabetic embryopathy, abortions, congenital anomalies, and diabetic fetopathy, macrosomia, last size baby, fetal hyperinsulinemia. And overall mortality is also increased by twofold in female with diabetes, and risk of fatal congenital heart disease or stroke showed greater risk in women. So with the advent of medical facilities, the CHD or the cardiovascular risk factors and the mortality has reduced in male gender, but the female population of diabetes still did not show any improvement of risk factors to cardiovascular diseases over time. And postmenopausal women at higher risk for ischemic stroke than men of comparable age, and the recurrence is also noticed in them more in women independent of age. So to conclude, women with diabetes are more prone to untoward outcomes more than men in South Asian region because of various cultural, behavioral, and ethnic activities. Affected women definitely require special attention. And so early diagnosis, optimum and adequate treatment of diabetes, regular monitoring of risk factors and comorbidities can reduce overall as well as cardiovascular morbidity and mortality. The approach should be patient-centric, gender-specific, holistic therapeutic approach should be adopted. Medical as well as societal support is mandatory to reduce diabetic burden in affected women and their future generation. Thank you for the patient hearing.
Thank you, ma'am, for an excellent deliberation and specifically highlighting the key pathophysiological differences between diabetes in men and women. So now I invite Dr. Harmandeep Kaur, ma'am. So ma'am will discuss about the various criteria for GDM and which criteria to be followed. Over to ma'am.
Hi, good evening. So I will just share my screen. So it is not letting me share. I think you will have to allow me. Okay. Okay, so can you see my slide? Okay, thank you. So thanks, Rajal. So now we are at our next presentation, which is about the diagnosis of GDM, which is gestational diabetes mellitus. So you will be happy, like I have a very short presentation just about the different criteria. So gestational diabetes mellitus, as we all know, this is just like any degree of glucose intolerance with the onset or first recognition during pregnancy. So it can be any time. Ideally, like we all know that the insulin resistance during gestation, it increases by mid-gestation around 20 weeks or so. But to make it more convenient for diagnosis, because it is very difficult to find out like in which trimester or which week it was diagnosed and all. So all glucose intolerance being diagnosed during gestation, they are called gestational diabetes mellitus. So why do we need it? Why we want to diagnose gestational diabetes mellitus? Because we all know that there are two generations at risk. One is mother and one is fetus. So in mother, we all know we can have different complications, like there can be increased risk of preeclampsia, UTI, hydramnios, and increased risk for cesarean section. As far as fetus is concerned, if there is pre-existing diabetes, the fetus can have embryopathy, then there is risk of macrosomia, metabolic abnormalities, respiratory distress, hypoglycemia. So all these things can happen with the fetus. So it is actually very important to diagnose as early as possible, because it can be pre-existing diabetes as well. So because of these reasons, because of increased risk to mother and the fetus, we need to diagnose it early. So what is the problem status? Like, where are we as Indians, as Asians? So we all know we are a high risk ethnicity anyways. In our population, the prevalence of diabetes is so high. That's why we have to be little extra cautious. So if we talk about the prevalence in India, so the data from you can say it was published in 2008. At that time, the prevalence was found to be around 6 to 9% in rural areas and 12 to 21% in urban areas. And we all know that it would be maybe it is much more now, because we all know, because of the changing scenario, like more migration to urban areas, changing lifestyle, increasing maternal age. So all these factors, they do play a role. And and if we compare it with the Western population, so we are, as far as GDM is concerned, we are thought to be like having risk almost 10 times it is written. So then if we are at so high risk, then does this apply to us, like who should be screened? So as far as status world over is concerned, we there is always a debate like who should be screened, because there may be unnecessary burden on healthcare. And but as far as India is concerned, I think because we are at very high risk, so the prevalence of diabetes, the gestational diabetes, is so high in our population. So I think so everybody should be screened. And in like other countries also, they consider Asians as high risk, and universal screening is preferred in Asian ethnicity. So if we see the data, if they, this is not about Asians, this is overall, even in populations where the risk, risk of gestational diabetes is low, even in them, when they studied the prevalence. So if they checked in high risk pregnant female, they found 1.4% risk, and when it was universal screening, the prevalence of GDM was 2.7. So it almost doubled. So that means, like, if we are doing only high risk screening in other ethnicities, I'm not talking about India, even then you are missing 50% of the GDM females. So the next important question is when to screen. So that is again a question as far as the Western societies are concerned. But for India, again, I would suggest, like, because here the prevalence of as such diabetes is so much, like patient can have even the pre-existing diabetes. Screening should be as early as possible. So initial screening at first prenatal visit only is necessary. And if at that time it is negative, then it can be repeated at 24 to 28 weeks. So again, but the problem is, like, what criteria to follow. So at first prenatal visit, again, we don't have any specific guidelines. Different people, they use different criteria. So in India, the WINGS 2012 study, it has kind of recommended that you can check any sugar with HbA1c, preferably fasting sugar. And if that everything is normal, then you can plan your next OGTT at 24 to 28 weeks. But again, there are issues. Ideally, it should be OGTT at the beginning as well, and then should be repeated at 24 weeks if initially it was normal. So what are the different criteria? Initially, WHO in 1999, it gave one criteria, like after 75 grams of anhydrous glucose. So fasting sugar should be 126 or more, and after 75 gram of glucose. If it is more than equal to 140, it should be considered as GDM. But you can see like fasting glucose criteria was very high. So 126 is too high for pregnancy. So people, mostly societies, they were against this. So after that, we had, so there is one DIPSI criteria, which is like mostly kind of Indian criteria. So here, this study was basically like the proposed criteria was basically for the developing countries which are like kind of resource poor, where the pregnant females, they may not visit that frequently, and it was kind of proposed not to miss any GDM at first visit only. So what was their proposal? Like you should do OGTT just whenever that pregnant female comes, and just check at 2 hours. Fasting is not at all required. And if it is more than equal to 140, it is just take it as GDM. So although for a resource poor developing country where especially in rural areas where we don't have kind of healthcare facility, or there's so much awareness in people, where we may lose a case which may not come back later. So it is a good criteria to follow. But what are the problems here? So when this study for validation, you can say when the comparison study was done, it was published by V. Mohan et al. What they saw was that when they tried to diagnose by different criteria. So when they applied WHO criteria, they diagnosed like 83 females, and by DIPSI there were only 23, and IADP criteria, it was 106. So when we compare all the 3 criteria, so DIPSI come out to be very low in sensitivity. So that means we are gonna miss a good number of cases in ideal scenario. Otherwise, in like rural areas where patient may not be coming and all, even this percentage of pickup is good. So the problem here is that although it is specific, but it is very low sensitivity. The second problem with this is diurnal variation. People say like we don't have good data to suggest like what cutoffs should we use during the different times of the day, because insulin resistance may vary during the day. So there was another study where again the DIPSI criteria was studied. It was found that in that study, they missed 22% pregnant females by DIPSI criteria, because we didn't check fasting sugar. So 22% of GDM cases, they had only fasting sugar elevated. So that is another problem. Like we are not checking fasting, and sometimes it may be only the fasting sugar to be very high. So then we had this famous study, HAPO study. So where around more than 20,000 of pregnant females, they were studied, and it was a blinded data. They compared their sugar levels with after OGTT with the outcome. So the more strongly associated things were birth weight more than 90th centile, cesarean sections, neonatal hypoglycemia, and cord blood C-peptide more than 90th centile. And they categorized the sugar levels in 7 categories. So category 1, 2, 3, 4, and I will just tell about the category 5 and 6. So you can see that there was a continuous association between the sugar levels and the outcome. So there is no as such single cutoff point where you can say for diagnosis of GDM, but you can very well appreciate that it is about the category 5 and 6 where actually there is a proper bend in the graph. So according to this HAPO study, which was actually outcome based, so different criteria was selected, and which we know as IA-DPST criteria. So here I have put all the different criteria in a tabulated form. So WHO initially in 1999, it was 126 and 140 at 2 hours cutoff. The American College of Gynecologists, it has suggested prolonged OGTT after 100 grams of glucose with 3 values, 1 hour, 2 hour, and 3 hour. You can see different cutoffs. IA-DPST criteria almost similar to ACOG, but here the fasting sugar is even lesser. So from the HAPO study where I told you about the category 5 and 6, so from there, so category 5, it started from around 89 fasting sugar. And 1 hour was around 180 and 2 hour around 150. So from there, they devised different cutoffs by different statistical methods. So this was the final cutoff at 1 hour and 2 hour. And the last one, DIPSI, as we discussed previously, only 2 hour sugar is being used. So if we compare ACOG with IADP, so in ACOG, because we are taking 4 values and 2 values above normal, they are considered to be GDM. And in IADP, we have only 3 values and 1 value above the range is considered GDM. And as per HAPO study, if we consider only 1 value, you will pick 11. So 11% of the GDM diagnosis, depending upon this criteria. So they will have only 1 value higher. So if we make it like 2, so it comes down to 1/4 actually. So if we are using IADP, we are picking up at least 4 times higher number of GDM cases. Now, the controversy regarding IADPG is that it is unnecessarily picking too many cases, by which we are burdening the healthcare, and along with that, increasing the anxiety in the mothers, where actually we may not require any treatment or dietary change actually. So that is the controversy regarding IADPG. If we tell about the other ones, so ADA 2015, it accepted both the criteria. Either you can go 1-step IADP or 2-step glucose challenge plus you can combine it with ACOG criteria. So any criteria you can use, but so with 2-step approach, there are some issues, like when you are doing glucose challenge first, you still may miss some cases. So NICE also came up with the criteria. So again, NICE has given guidelines, like in high risk cases, again, NICE is saying that you should check at the first antenatal visit only. And then at 24, you can do OGTT if initially it was normal. But otherwise, you can directly go with just 2 values, fasting and 2 hour glucose at 24 to 28 weeks for diagnosis of GDM. So after all these criteria, like where are we? Still, we don't have one good criteria. There are controversies around each and every. So if we are going little 1 step lower, so we are missing so many GDM cases. If we are using the very sensitive IADP criteria, so we are actually picking up too many GDM cases where, which may be unnecessary, which we still don't know, but still, we have only one outcome-based criteria, which is IADP. But my personal thinking is that if we don't want to miss any case and we want a good outcome, pregnancy outcome, and if we are careful for a mother, her future, because she has later on risk for type 2 diabetes as well, and for good fetal outcomes, so we should use a sensitive criteria only. But of course, in rural settings and in the developing countries, still 1-step approach may be used. when we can't use a good sensitive criteria. So that is it. Thank you.
Yeah, thank you, ma'am, for giving us an overview of the various diagnostic criteria with the advantages and disadvantages of each criteria. So now I invite the next speaker, Dr. Parjeet Kaur, ma'am. Ma'am will discuss the newer insights in the management of gestational diabetes mellitus.
Thank you, Dr. Rujul. Very good evening to all. I'll share my screen.
Yes, ma'am, there we go.
Okay. So, Dr. Harman has nicely explained when to screen and how to diagnose gestational diabetes. So, my job now is to talk about the management. Once the GDM is diagnosed, how to manage such cases. So, I'll be covering mainly management under these headings. First, the glucose monitoring and what are the targets, medical nutritional therapy, physical activity, then role of pharmacotherapy, timing and route of delivery, and finally the postpartum care. Now, once the GDM is diagnosed, the first step is to advise the lady to get the blood glucose monitoring done. That is the first step. We should not jump upon any of the pharmacotherapy or any kind of therapy. First thing is ask the lady to go for the self-monitoring of blood glucose. And self-monitoring of blood glucose, or SMBG, what we call is superior to any intermittent office monitoring of plasma glucose. So, if possible, one should invest in glucometer, but of course, we are also talking about here in resource poor settings. But those are the different, I think, scenarios where we might have to go for a little less monitoring. But in the setups where one can afford a glucometer, one should definitely go ahead with this. The advised timings for checking the blood sugar levels are fasting and the post meals. And among the post meal readings, it can be performed either 1 hour or 2 hours. Now, 1 hour or 2 hour postprandial, there is no evidence as such to suggest superiority of either approach. So either can be done. Earlier, there was some reports of showing that 1 hour postprandial glucose is correlated more with macrosomia and other outcomes. However, there is no robust evidence for that. So either you can ask the lady to get 2 hours post meal or 1 hour, or maybe we can get a mix of both the readings. Role of CGM is also there in certain situations where you're finding either there are fluctuations or for a better fine tuning, or maybe for a convenience point of view also this can be done. So role of CGM has also been explored in GDM. So the targets as the AD and ACOG are concerned, the targets for blood glucose control and GDM are fasting. We need to keep it below 95. 1 hour post meal, we need to keep it below 140. And 2 hour post meal, it has to be less than 120. If you look at the right side here, these are the targets for women with pre-existing diabetes. It is not GDM. Mostly, if you see, the upper targets are the same. However, here they have defined the lower targets also, so that to get a more strict control of blood glucose, that the lower can be as low as 70 in pre-existing diabetes, 1 hour lower 110, and 2 hour lower 100. So overall, keeping in mind these targets, one should go ahead with the SMBG. Along with advising for SMBG, one should also advise for the medical nutritional therapy. So this is not just the dietary advice or diet counseling. This has to be a very specific dietary advice, what we call as medical nutrition therapy. This is defined as a carbohydrate controlled meal plan that promotes the adequate nutrition, appropriate weight gain. So a lot of emphasis has been given here that weight gain has to be appropriate. It is not that every pregnant lady should gain this month 10-15 kgs only, then only it's healthy. No. So it depends upon the pre-existing BMI. One should aim for a certain amount of weight gain. Normoglycemia is the goal, and absence of ketosis. Because if we are going for a very low calorie restricted diet, that can lead to ketosis also. So we need to avoid that. So in 80 to 90% of mild GDM cases, this can be easily managed by medical nutrition therapy, and we need not give any pharmacotherapy. So therefore, this MNT or medical nutrition therapy has to be prescribed by a registered dietitian or a qualified individual. So the goal, as I just mentioned, these are the goals. So what is exactly it covers? ADA says that this kind of medical nutrition therapy has to be done with the guidance from the dietary reference intakes, which recommends that minimum of 175 grams of carbohydrate, minimum of 71 grams of protein, and 28 grams of fiber. Emphasis should be given on the monounsaturated and polyunsaturated fats, limiting the saturated fats and avoiding trans fats completely. So the amount of carbohydrate which is coming out to be 175 grams is around 35% of a 2000 calorie diet. ACOG says in terms of percentage that carbohydrate intake should be limited to 33 to 40% of the calories. So if you can see, this is like a little carbohydrate control diet with the remaining calories to be divided between protein 20% and the fat 40%. So this much of proportion should be taken into account, and that's how this medical nutrition therapy should be planned by a registered dietitian. Now, this one I was talking about the weight gain during pregnancy. So there are now, we are focusing more upon the appropriate weight gain rather than aiming for weight gain in all the pregnant ladies. So here, depending upon the pre-pregnancy BMI, if you look here, the advocated or the advised weight gain mean in kg per week. For example, if the lady is underweight, then it has to be on the higher side, 0.5 kg per week, with the cumulative range of weight gain over throughout the pregnancy should be around 12.5 to 18 kg. With the normal weight, 11 to 16 kg, with this much 0.42 kg per week. Overweight, you're coming down here now, 7 to 11.5 kg overall is the target, with just 0.28 kg per week of weight gain. In obese ladies, you're going down further, with just 5 to 9 kg of weight gain is enough. So you're not targeting a very high weight gain in these ladies. And with a mean range of around 0.22 kg per week is the target here. Next step is to advise the physical activity. This is equally important. So exercise, because has been shown to improve glycemic control. So moderate exercise program is recommended, which is aiming for 30 minutes of a moderate intensity aerobic exercise, at least 5 days a week, or a minimum of 150 minutes per week. So this is also what is recommended in non-pregnant people also with type 2 diabetes, but moderate intensity is what is advised, which can be in the form of a simple walking or a slight or a cycling can also be done, but heavy physical activity with jerks are involved need to be avoided. So simple exercise such as walking also, especially after each meal, 10 to 15 minutes after each meal, can also lead to a marked improvement in the glycemic control, and it's commonly recommended because in GDM, what we find is because of the insulin resistance, there is a marked increase in the post-meal blood glucose levels. So the post-meal 10 to 15 minutes of a simple walk can help bringing down in those blood glucose levels. And in fact, in some ladies where it is difficult, that ladies are getting tired because of the walking, they can simply sit in the chair and do some arm exercises for 10 to 15 minutes for after the meal, which can also help in bringing down the blood glucose levels. Now, coming on to the pharmacotherapy. So when should one consider the insulin therapy? So these are the glycemic threshold for initiation of insulin. So once the self-monitoring has been done for at least 2 weeks, you advise lady to get it done while on medical nutrition therapy. This is important that she has followed strictly the advised diet. And still, if you're finding the targets are not achieved, that means the fasting is remaining more than 95, 1 hour post-meal is more than 140, or 2 hour post-meal is more than 120, then you go for insulin therapy. And in the insulin therapy also, the option which is preferred, the insulin regime which is preferred is the multiple dose, where we are combining the short or a rapid acting with the intermediate or the long acting. Premix insulin has also been used in some cases, but in GDM, especially premix does not been preferred. However, in ladies who have pre-existing diabetes, who were taking premix insulin, well controlled, can be continued. But if you're planning to start the insulin therapy during pregnancy, preferred regime is the basal bolus or the multiple dose insulin. Coming on to which insulin now. First thing is very, very clear that none of the currently available human insulin preparations have been demonstrated to cross the placenta. So which means that all the insulins are pretty much safe because they do not cross the placenta. A lot of insulins have been studied, and some of the insulins have been studied in randomized control trials, some have been studied in cohort studies, and some have case reports only. In terms of RCTs, we're well conducted randomized controlled human trials are available. We have these insulin, regular insulin, NPH, aspart, lispro, and detamir. These are the well studied in humans also. Insulin which are in cohort studies have been done are glargine and degludec. Insulin in case reports, we have Fiasp, glargine 300, and glulicin. Now, FDA earlier had categorized these drugs in category B or category C, where first list were all category B here, and subsequent these lists, degludec, glargine, glulicin were category C. However, 2015, FDA has said that we cannot use this lettering system now. We cannot use A, B, C, D. What we need to now emphasize is which drug has been studied in humans and which drug has studied in only on animals. So category B means that these drugs have been studied in humans also, and category C means only animal study, no human studies. So giving a label of C was little alarming earlier, and these drugs were not used. However, recently, in glargine U100 and glargine 300, this category C has been removed. And what has been labeled here is that no human pregnancy data is available. So which means that you're in the sense implicating that this drug has no human study available and only animal safety data is there. So this has to be discussed with the patient that this is no longer that it's category C and cannot be given. And subsequently, in fact, now FDA has advised that all the drugs in pregnancy will have to be reported like this. We cannot label as ABC. So as far as glargine is concerned, and other long basal acting insulins are concerned, many insulins have been used in pregnancy. We have data from cohort studies and case reports as well, where they have clearly shown safety. And we are also using pretty much these insulins, especially glargine, when the patient is very well controlled on glargine. In fact, a lot of time we do feel that giving an NPH or a detamir twice daily is not leading to a good glycemic control. Then we do opt for these insulins, because they definitely lead to better glycemic control. So ultimately, we have to see that good glycemic control is our target. That is causing a more risk, that is posing a more risk rather than the insulin itself. So in terms of regime, which insulin regime to use, as I mentioned, multiple doses are required in most of the cases. And initially, if you see, when you ask the lady to do a self-monitoring, what you will observe in majority of the cases is just the post-meal rise which is happening. So in such a situation, what you can do is you can just go ahead with the rapid acting insulin only before each meal, because these ladies usually have a good endogenous basal insulin. So just 3 boluses in a day will be sufficient. However, if you're finding that both fasting and post meal are high, in that case, you will have to add a long acting either at bedtime or in the morning once daily of ultra long acting or long acting, or if you're using NPH or detamir, you might have to give twice daily. Now, coming on to oral antidiabetic drugs, metformin I'll be discussing specifically because there has been now recently some data on metformin and it has been increasingly used also in GDM cases. What ADS says clearly that insulin is the preferred medication for treating hyperglycemia and GDM. Metformin and glyburide, or glyburide, what we have here is glibenclamide. It should not be used as first-line agents as both cross the placenta to the fetus. This is very clear. All the oral antidiabetic drugs, they cross placenta. So they are not the preferred first line. And moreover, these oral and other non-insulin injectable glucose-lowering medications, they lack the long-term safety data. And even it states that metformin, even when used for PCOS to induce ovulation, should be discontinued at the end of first trimester. So this is very clear class A evidence here that insulin is the preferred treatment. ACOG also says that insulin is the preferred treatment because oral anti-diabetic medications are not approved by FDA. OADs cross the placenta. They lack long-term neonatal safety data. However, it also notices that the summaries of this current medical literature, they have a poor trial quality trials. They're not designed to assess the equivalence or non-inferiority. So we do not have a very good robust data on OAD in terms of the safety data. It also emphasizes upon the point that some clinical situations might necessitate the need of metformin and rarely glyburide. So metformin can be considered in ladies who decline insulin, who are unable to safely administer insulin, who cannot afford insulin. Those are the cases. In PCOS cases, sometimes it is also used, especially when the lady is already on metformin when she conceived. And if you're finding that glucose levels are high in the first trimester itself, not a overt, but a impaired fasting that can be continued at that point of time. If the lady is obese and requiring a very high doses of insulin as the pregnancy is advancing, you're finding that insulin resistance is coming up, that is the point where you can add metformin. Or if the history of impaired glucose tolerance is present in the past, that here also metformin can be considered. But in any case, discuss the limitations of the safety data and high rate of treatment failure requiring insulin in ladies. So take the patient into confidence, discuss the problems with the long-term safety data of these drugs, and if necessity, if required, can be added in such certain clinical situations. So we have a meta-analysis also in these drugs and insulin. So this was a meta-analysis published in 2021 where 6,000 women on pharmacotherapy was studied, where metformin versus insulin, glibenclamide versus insulin was compared. And what was found with the metformin, there were good outcomes in terms of maternal metabolic outcomes in the form of reduced weight gain, hypoglycemia, and reduced neonatal hypoglycemia. Fetal outcomes were also good in terms of less likelihood of LGA babies. Pregnancy outcomes potentially reduced pregnancy-induced hypertension, preeclampsia. However, these benefits were not seen with the use of glibenclamide. So it was concluded that compared to insulin, metformin was associated with more favorable outcomes for the treatment of GDM. Glibenclamide was less favorable, and future studies, of course, is needed in terms of the long-term infant outcomes. So when we talk about long-term infant outcomes here, there also we have a study which was published in 2019. This is again a meta-analysis which was done where it studied the neonatal, infant, and childhood growth following the metformin versus insulin treatment for gestational diabetes. And what was seen here that following the intrauterine exposure to metformin, neonates are significantly smaller than insulin-treated group. Metformin-exposed children then again had an accelerated postnatal growth, resulting in heavier infants and higher BMI by mid-childhood. And such patterns of low birth weight, postnatal catch-up associated with adverse long-term cardiometabolic outcomes, which means that we need further studies to examine the longitudinal perinatal and childhood outcomes following intrauterine metformin exposure. Coming on to the timing of delivery, if the GDM is well controlled with diet and exercise, just as normal pregnancy, we are planning normal delivery should be planned, not before 39 weeks, of course. If the GDM is well controlled on medication, you can consider delivery around 39 weeks. If it's poorly controlled, then expert opinion along with the consultation with the gynecologist, we have to trade off between the risk of prematurity and stillbirth here. Delivery can be planned between 37 and 38 weeks, may be justified. However, late preterm period from 34 to 36 weeks reserved for the failed in-hospital attempts of glycemic control or with abnormal antepartum fetal testing. Now, the GDM once happened, the story does not end there. That's the problem we see when the ladies, when the pregnancy is over, they get a healthy baby, they're done with it, they forget about their diabetes, but that's not a case because in long term, almost 60 to 70% of the cases of the ladies who develop, who have GDM, they develop type 2 diabetes over a period of 5 years. This is very, very important that lady should be well educated throughout the pregnancy about the long-term outcomes, adverse outcomes for her. Therefore, it's recommended that post-delivery, within 1 to 3 days, the test which is recommended is just a fasting or a random glucose to detect the persistent over the overt diabetes. So many of these cases could be a case of overt diabetes or persistent that can be detected if the post-delivery you check the blood glucose. Subsequently, early postpartum, that's 4 to 12 weeks, it's recommended to get a 75-gram glucose done, 2-hour OGTT done, oral glucose tolerance test, and classify the lady according to the results. Subsequently, at 1 year again, this OGTT should be done. Then annually, a fasting plasma glucose. And if everything is coming fine, then at least once in 3 years, you should keep on monitoring to detect any development of prediabetes or diabetes. And once the lady plans for another pregnancy, then again, a 75-gram 2-hour OGTT should be repeated. So this will be the plan. You get a 6 to 12 weeks postpartum fasting plasma or a 75-gram OGTT. where you classify the lady as having diabetes if she meets the criteria for that and go for diabetes management. If she has impaired fasting or IGT or both, here you can consider lifestyle management, weight loss and physical activity. Metformin can also be considered. If it's normal, assess the glycemic status every 3 years, but emphasize upon the lifestyle modification, weight loss and physical activity forever for such cases, because GDM is a very high risk of developing type 2 diabetes in future. So take home messages. Once GDM is diagnosed, prescribe the nutrition therapy, exercise and self-monitoring of blood glucose. That's the first step. If the SMBG values are above the target range, insulin is the first line therapy for a better glycemic control. And the standard insulin regime is basal bolus regime. Insulin use in pregnancy must meet the needs of the patient, and the existing level of control may be more important than the pregnancy category. So again, emphasizing we need to keep the blood sugar in tight control rather than emphasizing more upon the category here. For metformin use, you counsel that long-term safety data is limited. However, if required in certain clinical situations, can be used. And it is imperative that all women with GDM, they receive appropriate postpartum management and long-term follow-up. Thank you very much.
Thank you, ma'am, for delivering an excellent deliberation on the newer insights in the management of GDM. So now it's time for our final presentation. So now I invite Dr. Amy. Ma'am will discuss about the management of pre-gestational diabetes. Over to you.
Yeah, thank you. Thank you. So, are my slides visible?
Yes, ma'am, they are visible.
Okay. Thank you for inviting me. So we had a very detailed presentation from Dr. Parjeet about the GDM. So why are we discussing about the pre-gestational diabetes? So what happens that it is not just the diabetes which is diagnosed during pregnancy. The patient has the diabetes and other comorbidities, that is like hypertension, dyslipidemia, dysglycemia, and insulin resistance. And along with that so we have to manage that in totality rather than just the glycemic control. So here the management starts from the pre-pregnancy. So we have pre-pregnancy, during pregnancy, and the postpartum. So if we see what are the differences from gestational diabetes, that this pre-existing, that it may be a type 2 diabetes or it may be a type 1 diabetes. So I'll be discussing about the type 2 diabetes here. We know that these patients have pre-existing diabetes, so they have more adverse effects. Since the diabetes is present, so the patient has more, maybe having the diabetic complications which have to be addressed. So these complications can also lead to the adverse outcomes during the pregnancy, and also the diabetic complications may worsen. And unlike GDM, where the onset of dysglycemia is around second trimester, here the dysglycemia is already existing. So during the embryogenesis, so that leads to the increased risk of complications like congenital malformation. So these patients actually require more intensive monitoring. We have talked that GDM, usually they will be treated with a dietary modification, but these patients will usually require high doses of insulin. And also we need to have close follow-up. So, but the biggest barrier is most of the pregnancies are unplanned, and usually the preconception care is lacking. So what is the outcomes if we see? If we see as compared to the normal population, there is 4 to 5 times increased risk of malformation. This again depends upon the level of glycemic control, HbA1c. There is increased risk of preterm deliveries, and also there is much higher risk of LGA infants. And also the perinatal mortality is almost increased from 3 to 4 times as compared to the general population. So what does hyperglycemia? As I already said that these ladies already have hyperglycemia in the preconception period. So there is a dose-dependent increased risk of congenital malformation. As we see that as the HbA1c increases, these patients have increased risk of this increased risk of congenital malformation. So if the patient has HbA1c which is less than 6, the congenital malformation is almost 1 to 3%, which is comparable to the general population. But as we go down, the HbA1c keeps increasing. The risk may be as high as 20 to 25% at 12% HbA1c. And also there is increased risk of spontaneous loss and perinatal mortality. So what is important is that we maintain the HbA1c level in the normal ranges. So that's important because there is the timing of congenital malformation in the early pregnancy when the ovulation is taking place. After 3 to 4 weeks, there can be caudal regression with hyperglycemia, which is almost pathognomonic of diabetes. Then the most common abnormalities that are seen in a diabetic infant or a diabetic embryopathy is the neural tube defects, which can be spinal bifida, anencephalus, or and second most common is cardiovascular malformations like atrial septal defect, PDA, transposition, and even anal atresia. So because of these reasons, we should target for HbA1c as close to the normal as possible in a patient who is planning pregnancy. So we see in case of GDM, we have already talked that once if the patient has GDM in the second trimester, there is increased risk of macrosomia and metabolic complications. These do persist in the women who have pre-existing diabetes. The risk of macrosomia is almost 3 to 4 times because child is exposed to dysglycemia for a longer duration of time and it has neonatal complication, and also the long-term sequelae are there. And also in the mother, because of pre-existing hypertension, there is increased risk of preeclampsia, and all these preeclampsia also may lead to IUGR and early fetal loss. There is increased risk of spontaneous fetal loss, which is seen in almost 2 to 3 times as compared to the normal population. So what is important that is we need to give a good preconception care. So what all components we need to do? The patients should have a healthy lifestyle prior to the preconception. Try to optimize the weight. We have to tell them if there is 10% weight loss, that is going to improve their dysglycemia, improve their metabolic complication. And also it has been seen that if there is an obesity, this is going to increase the risk of fetal malformation as well as cardiovascular abnormalities. So these patients should be encouraged to lose weight, and you have to optimize the glycemic control. The biggest factor, the biggest teratogenic factor is dysglycemia. So we have to achieve the glycemia control should be as near the normal, but most of the guidelines say less than 6.5. And also then we have to give them the diabetic plan to the patients. So when do we start this preconception counseling? As we said that almost 50% of the pregnancies are not planned. Most of the patients will present in the pregnancy around 12 to 14 weeks. It is only the IVF patients or the patients who are being treated for infertility, they will present early for the glycemic control. So any women of reproductive age group, we have to emphasize that good glycemic control is important to decrease the risk of fetal malformation, and they should have effective contraception till the HbA1c is less than 6.5. And also there are certain guidelines like ACOG guidelines. They said that HbA1c should be less than 6%. So try to maintain it as near normal, like fasting around hundreds and postprandial less than 140, so that there is minimal risk of fetal teratogenesis. And then second is weight. And also it is important that we have to tell the patients about the diabetic skill management prior to the pregnancy, that how to monitor the blood sugars, what should be the target, how to manage the hypoglycemia, and also the other things like folic acid supplementation from 400 micrograms to 5 milligrams, which have to be started. And also very important is that we have to evaluate and treat the diabetes related complications like neuropathy, retinopathy, and nephropathy. So it has been seen that if there is a good preconception care, that itself decreases the risk of congenital malformations. So as I said, the euglycemia is the most important factor, and it has been shown in various studies that if this is attained, there is decreased risk of congenital malformation, spontaneous abortion, preeclampsia, and progression of retinopathy. So how do we do the glycemic control? The biggest, like a patient who comes to 3 to 4 months prior to planning an IVF or a pregnancy, what should we continue the patients on OHA or shift to insulin? So most of the patients who have pre-existing diabetes will need insulin during the pregnancy. So it is better that we should switch all these patients to insulin prior to pregnancy, even if the glycemic control is maintained. Maybe only in the patients who are only on metformins, if they insist, they can be continued. But mostly we should try to shift these patients on insulin. The rationale is that we need to determine the ideal insulin dose prior to the embryogenesis, and also it will the patient will get used to taking insulin, monitoring blood glucose, and how to adjust the insulin dose. And we have to explain that these OHAs are likely to fail during pregnancy, and which insulin regime we should use. We should always switch over to the basal bolus insulin if the patient is on multiple OHAs. If the patient is only on metformin, maybe the bolus insulin is enough. So none of the hypoglycemics have been approved for pre-existing diabetes in pregnancy, though glyburide and metformin has been used in the RCTs in GDM, as already discussed by Dr. Parjeet. So eventually most of the patients will need insulin. So it is better to shift them on insulin prior to pregnancy, maybe 3 months prior, so that they get to know about the insulin, its dose adjustment, and how to take insulin, and some dose can be adjusted. So how do we screen for the diabetic comorbidities? The major comorbidities which advance during the pregnancy is diabetic retinopathy. So in all patients, we should have a dilated fundus examination prior to pregnancy, and it has been seen that there is significant progression of NPDR, and it all depends upon degree of euglycemia, duration of diabetes, and also in patients who are associated hypertension, they have higher risk. So in these patients, we should monitor more closely. So all guidelines say that first trimester monitoring should be done, but second and third trimester depends if the patient has pre-existing retinopathy or patient has risk factor for progression of diabetic retinopathy. Since the retinopathy progresses 1 year postpartum, so we should do the postpartum screening also. So what other tests can be done in case patient has retinopathy? So in case of pregnancy, FFA is a category C. Unless it is very urgent, it should not be done. And if the patient has severe NPDR and PDR during pregnancy, they can undergo laser coagulation. But most of the guidelines say that if patient has CSME, the laser may be deferred during pregnancy, because usually the CSME may reverse in the postpartum stage, and the use of anti-VEGF factors is not. It is a category C, that there is less data. So all these patients need to have postpartum monitoring. And for nephropathy, all the patients, we should have a creatinine evaluation, and also the urine albumin to creatinine ratio prior to pregnancy and also during pregnancy. And if the patient has some degree of nephropathy or albuminuria, this should be done every month in the pregnancy. And if the patient has nephropathy, the risk stratification should be done, that there is increased risk of overt nephropathy, preeclampsia, preterm delivery, and fetal growth retardations. And we should target, the most important is that we should target the BP less than 130/85. Ideally, the ACE inhibitors and ARBs should be stopped prior to the pregnancy. But in some patients who have severe albuminuria, we have to tell them about the risk and benefit of discontinuing drugs. But once the patient conceives, they have to be stopped. And we have to rather switch on to the calcium channel blockers, methyl dopa or hydralazine. And if the patient has any risk factor for cardiovascular disease, then we should always get an ECG. And if further required, these patients need to be worked up. So how do we optimize the glycemic control in the pregnancy? This has been very well explained by Dr. Parjeet. These patients we know will be always on insulin. The OHAs are not advocated during the pregnancy. All the patients have to be shifted prior to pregnancy on insulin. But if they present during pregnancy, then it is better to shift them to the basal bolus insulin. What are the challenges during management of pregnancy is that there is varying insulin sensitivity. For example, a patient who gets pregnant on insulin during the first trimester, the insulin sensitivity may increase, and especially these patients may present with a morning hypoglycemia. But after 20 weeks, there is significant increase in the insulin resistance, and these patients will need very high doses of insulin, around 0.8 to 1 unit per kg body weight. And also in the first trimester, there may be nausea, vomiting, and change in appetite. So we have to educate the patients regarding the insulin dose adjustment, management of hypoglycemia, and the strict monitoring. So we've already talked about that. What are the glycemic target? These are the CGMS values which have been done in the diabetic patients. So the guidelines have already been discussed. I'll just reinforce that the fasting glucose is maintained around 70 to 95. 1 hour blood glucose values, the lower value of 110 to 140, or the 2 hour values of 100 to 120. So these patients need to get at least 1 fasting and 3 post-meal values, which can be 1 hour or 2 hour values. If the patient is going into low blood glucose, like 2 hour values are less than 100, we should try to decrease the insulin, because that has been linked with a small for gestational age babies. But if it is the patient is on diet control, these lower limit do not fall. So there is also a role of CGMS data. So if CGMS helps in maintaining the better target and range, in case of type 2 diabetes, almost 80% of the times the patient should be in target and range, with less than 5% having hypo or hyperglycemia. So we have already discussed that these patients don't need to have, because most of the type 2 diabetics will be obese. The weight gain is in the tune of 5 to 9 kg if the BMI is more than 30. And if the BMI is more than 35 kilogram per meter scale, then there is no data on optimum weight gain. So we have to explain that patient that they do not need to have similar amount of weight gain as in the case of thin patients. So they have to follow the diet and nutritional therapy as well as exercise guidelines, which has been very well elaborated by Dr. Parjeet. So again, coming to the oral hypoglycemic agents during pregnancy, the metformin and glyburide, there is some data of use. There is actually large data of use in the pregnancies. But again, none of the guidelines do recommend giving metformin or glyburide. What is the problem in case with a patient who is already a pre-existing diabetes? These patients have severe hyperglycemia. They have higher insulin requirements, so they are unlikely to get responding to the oral metformin therapy. So most of these patients will need insulin therapy. So metformin is occasionally given add-on therapy. We know we have already discussed that there is a lot of data of metformin that it decreases the maternal weight gain, which is useful in patients who have already type 2 diabetes, because most of them are obese. And also it causes decreased risk of neonatal hypoglycemia and less NICU admissions. But most of the meta-analysis have showed that there is some higher proportion of these infants have SGA babies. So there is around increased ratio of patients may have small for gestational age babies. So most of these studies were done in actually patients who had GDM or PCOD. Now there is a recent trial that is metformin in pregnancy in type 2 diabetic patients. They had taken almost 500 diabetic type 2 preceding diabetes and given metformin along with insulin from 6 to 22 weeks. They didn't find any difference in the serious neonatal outcomes between the both groups. And the metformin was associated with some improved outcomes like improved maternal glycemic profile, decreased neonatal adiposity, reduced maternal weight gain, and lower insulin requirement and fewer cesarean. But there were more SGA infants in the metformin group. So where do we give the metformin in patients? It has not been approved. We have to explain to the patients that alone metformin is unlikely to achieve the glycemic targets. It can be given add on to insulin in patients who have very high insulin requirement or rapid weight gain. But there should be caution in pregnancies who are at risk of fetal undernutrition. And what is its role in the first trimester? That is not known because the long-term data is not available. As Dr. Parjeet had discussed, there is some data, there are multiple meta-analyses which have been done in the kids from 2 to 7 years. And there are few meta-analyses. This is a recent meta-analysis which showed that these infants are actually heavier. So how does it changes the energy metabolism is not known. So we don't have long-term data. Until now, insulin is the safest drug. So the insulin also we have discussed that it has to be basal bolus. It can be NPH or detamir. And if the patient is on glargine, well controlled, that can be continued. Degludec, there is a recent data which is coming up and it might be approved in near future. And in the bolus, we have a SPART regular, which are most commonly used. So how do we manage hypertension? The BP should be less than 135 by 85, but it should not be lower than 110. That can decrease the fetal growth. ACE inhibitors and ARBs should be stopped. And the drugs we said that like calcium channel blockers, methyl dopa can be used. And all these patients who are hypertensive or have some degree of albuminuria, creatinine and albumin creatinine ratio has to be done 4 weekly. All these patients have to be started on low dose aspirin, which is started at 12 to 16 weeks to lower the risk of preeclampsia. Actually, the KDIGO guidelines give that this can be started even prior to the pregnancy also. And in case the patient has nephrotic range proteinuria, they have to be started on low molecular weight heparins. So during the labor and delivery, usually the requirement of insulin decreases. So how do we manage? Either it has to be an IV insulin infusion with 5% DNS, or it can be titrated according to the sliding scale. But most of the times we use this insulin infusion with DNS. And after delivery, we have to be careful because the insulin dose requirement significantly decreased to half or 1/3. And in the postpartum, we should try to maintain the blood glucose around 100 to 180. And in the postpartum, since the mother is feeding the child, then we have to be careful about the hypoglycemia. So again, in the postpartum, the dose of insulin has to be decreased. Metformin and glyburide has been used in the postpartum, though metformin is transmitted through the breast milk, but the concentration is very low. If the patient has mild degree of dysglycemia, it can be given. And again, we have to manage the diabetes strictly in a patient in the postpartum as we manage any other type 2 diabetic. And we have to be careful about hypoglycemia because the energy requirement during lactation increase. Most of the OHAs does cross breast milk, and the insulin is the drug which is the safest. And we should encourage the mother for breastfeeding. That will help in weight reduction and also improve the fetal metabolic profile. And then again, the diabetic education has to be given. So just concluding, we have to manage a pregnancy in a diabetic women so that we get the outcomes which are similar to the non-diabetic women. So that in a patient who is already pre-diabetes, the management actually starts from the preconception, and any woman of reproductive age group is actually, we have to start the management there strictly for glycemic control and try to achieve euglycemia as much as possible. Thank you.
Thank you, ma'am, for giving us a nice overview of the management of diabetes in the preconception period. So with this, we conclude all our presentations. So now I invite all the esteemed speakers for the panel discussion. And we will be simultaneously taking the queries from the audience as well. So the first question is to Dr. Parjeet, ma'am. So
Yeah.
Highlighted about the use of OADs in GDM. So according to you, which OADs are preferable for use in the management of GDM?
Okay. Thanks, Dr. Rujul. So again, emphasizing upon the fact that insulin remains the first line therapy. We do not have any long-term safety data with OADs. But if required in certain clinical situations, as I also mentioned in my talk, like ladies who are obese, who are severely insulin resistant, who have a past history of PCOS, where we want to start a drug, then metformin is the drug of choice there, because we have some data at least with metformin. And otherwise, other drugs have not shown to have any beneficial. In fact, in one of the meta-analysis, in fact, glyburide were associated with adverse neonatal and fetal outcomes. So metformin is the preferred one, and if required, can be started on the smaller dose initially because of associated nausea, and already in pregnancy can be started with 500, but at least twice daily is required to have a good effect, and subsequently can be stepped up, and we can go up to 2 grams as well.
Yeah, right, ma'am. So, ma'am, the second question is, so what long-acting insulins are used or can be used for management of GDM?
Right. So as I had shown in my talk, that long-acting with insulin, which are already approved, FDA approved, or who are classified as category B, or who have those insulins which have good human data, are the NPH and Detamir only. As far as the other newer generation basal insulin, long-acting insulins are concerned, like Glargine 100, Glargine 300, Degludec, we do not have human data. But then we do have cohort study observational data where these drugs, insulins, have been used without showing any adverse pregnancy outcomes, adverse neonatal outcomes. So they're very well much in use in pregnancy, these second generation insulin, basal insulins as well. And as I also mentioned, that FDA has not removed that category C from the Glargine 100 and 300, and it just simply states that it's not studied in humans. But if you can discuss with the patient, take the patient into confidence, if you really want to have a good glycemic control, because that is our main goal, to get a good glycemic control to prevent the complications. And if you're able to achieve this goal with the use of Glargine 100 and 300, then definitely we can use these second generation insulin as well, especially when the lady is already well controlled on Glargine. That must be continued.
Yeah, thank you, ma'am. So the next question is to Dr. Neelam, ma'am. So, ma'am, in your clinical practice, how often do you see young women with new onset diabetes? And specifically, what are the long-term consequences of young onset diabetes in women?
So with increase in obesity prevalence, type 2 diabetes is quite frequently seen in young diabetic, especially when as women are concerned. And they actually type 2 diabetes, when happen in young, then they have a little more disruptive course than when the onset is in adult onset, because there is, apart from insulin resistance, there is rapid beta cell decline. And in our own, I think, DOI registry, which we have, 25% of the cases, they were less than 25 years, 25% were type 2 diabetes. So it is definitely increasing. And with the increase in obesity, PCOD phenotype, insulin resistant, it is frequently seen. Definitely much, I would say, almost twofold increase has happened. And since they go for a longer haul, reproductive phase, pregnancy, so apart from risk to their health, if it is not adequately controlled, we have already discussed an entire session that it is risk to the baby also. And they have 40% increased risk of cardiovascular morbidity and mortality, because more visceral fat independently is a risk factor to increase CV mortality.
Right, ma'am. So, ma'am, in your opinion, are women more predisposed to diabetic complications as compared to men?
Yes, they are. And there's a lot of data physiologically also, because their visceral fat is more sensitive and have increased cardiovascular risk and that we have already discussed in our talk. And secondly, apart from physiological factors, there is social factor, behavioral factor. Family comes first. Then post GDM also, what happens is they have to feed for two people. So no adequate exercise, constant vigilance over their diabetes parameter doesn't happen. Less frequent monitoring, often poor adherence. All these points which we discussed. So definitely they see longer long-term complications.
Yeah, thank you, ma'am. So now I invite Dr. Sunil Mishra, sir, for to take forward the panel discussion.
Thank you, Dr. Rujul, for a wonderful conduction of the session. So thank you, Dr. Neelam, for such a nice answer. Though I do agree with you. There is a skewed data in the hospital. So we did one study on the liver fat, and then followed by some studies where the data was totally skewed. So more of the male people who are visiting hospital for the health check. I'm talking about the health check only when we took out the health check data, and very few ladies are coming for the kind of the health check or cardiovascular check in the hospital. So that data is really skewed, and that really tells about the kind of the care they are achieving and the poor follow-up, and obviously the long-term complications are going to be high. Thank you. So wonderful sessions by all the panelists. So I will ask question to Dr. Harman. So Dr. Harman, although you have already enumerated about the different screening tools for the diabetes in pregnancy and the screening methods. So always we have a discussion about this thing, that DIPSI and the IDA-PSG criteria. So what are the limitations, just for the reiteration of the whatever you have told? So let the audience learn once more. So how you will differentiate between the two.
Yeah, so DIPSI, as we know, like we are checking only the post glucose value. So definitely there would be limitations. So we are not checking fasting sugar. We are not getting, like we don't have any validation of this. Secondly, why we are diagnosing GDM, like we know cutoffs are very low to diagnose GDM, and then sugars should be very tightly controlled. So the thing is, when we don't have any outcomes related study, like if we are diagnosing by DIPSI, what are the outcomes, how many we are missing and all, that outcome data is not there. But definitely the gross diabetic patients we are not missing. So in resource poor settings, in rural areas where we don't want to miss any overt diabetes, definitely this will work well. But in urban settings, in where we can actually do better, actually, where all the facilities are there, definitely IADP will be better, because we are checking the whole profile of the patient. We have definite validation studies, we have outcome studies. So all the criteria, they were taken from HEPO, and then it was validated over time. So definitely that will be better. But of course, when you can't do anything, something is better than nothing. So definitely, so in those settings we can use that.
Agree, totally agree. So as we discussed that the criteria for the treatment of the diabetes are very stringent in the pregnancy and the gestational diabetes. I think this is the most stringent target given ever in the lifetime of an individual. So before labeling a person, a lady with gestational diabetes, so we have to be very, very sure that what we are doing, and rather than embarking on the treatment based on the screening category, which is again questionable. So when you have possibility, please follow the IAD-PSG criteria. So one more question, then I will come to Dr. Amy. So you just again a repetition of the whatever you have told regarding the universal versus selective screening, and how early, when to screen for GDM.
Mm-hmm.
Right.
Yeah. So that is like, yes. So for our Asian population, Indian population, we all know that it may be a pre-existing diabetes. Even we know that how many people, females we are diagnosing, even in like metros, like well-educated females, they will just get to know about diabetes when they did first checkup after pregnancy. So that will not be GDM as such, that will be pre-existing diabetes. Girls, they are coming with 8%, 9% HbA1cs. So in our setting, definitely we should encourage screening should be at the first visit. So even in Western eye, as I have given the data, like they are missing 50%, although because the prevalence is so less. So even after universal screening, the prevalence is just 4%, which is like 1/3 to half from India. But when they did high risk screening, they just missed 50% of the females. So universal is being proposed even for the Western population, even for the low risk groups, but definitely because we are the high risk. So at first postnatal visit only, we should try to pinpoint like what are the females at risk and what are the sugar levels. And then if it is negative, definitely it should be repeated at 24 weeks to find out like how is the insulin resistance or sugar levels later on. So for India, definitely it will be universal screening, and screening at first visit is very important.
Wonderful. So because this has a huge bearing, so suppose if we diagnose a lady first time in first pregnancy with the gestational diabetes, so her risk of, although she will have might have a normal glucose post delivery, but if we have not diagnosed well, not talked well about the long-term management, there is a fair risk of getting high glucose from the beginning of the next pregnancy. And so therefore, appropriate diagnosis is very, very important whenever we are dealing with this condition. So thank you, Dr. Harman, for a wonderful talk and your answer to the queries of the audience as well as from the panel. So most of the questions from the panel are from the audience are almost same. So now to Dr. Emmy, in case of pre-existing type 2 diabetes, how you optimize diabetes management, and how soon before planning a pregnancy it should be done? Although you have talked in detail about your presentation, but for a repetition to the audience, it should be told once again. Thank you.
Yeah. So any patient who of a reproductive age group who comes to us is actually, we should try to optimize her as soon as possible. Because if we see the almost 50 to 60% of patients are unplanned. This is the Western data. If our data is, most of them are unplanned. And then patients who come to us with planning pregnancy, usually they are the IVF pregnancies or patients who are being treated as a PCOD. So again, it will depend upon like what is the degree of glycemic control, what is the duration of diabetes. But at least I think 3 months prior to that, we have to start, because if it is a new onset of diabetes, maybe it is easier. If it is a long-standing diabetes patient who is on multiple OHAs, then we have to optimize. We have to start with insulin, optimize insulin. That itself will take 1 month, and then again 3 months to control. And again, if it is an HbA1c which is more than 10, maybe a longer duration. It all depends upon how frequent the patient is able to monitor, because most of these patients we are going to be shifting to the 4 times insulin, the patient who is on sulfonylureas and all. And also those complications like diabetic complications have to be looked into and rectified prior to pregnancy, whatever is possible. Yeah. And only thing is, the patient who come to us for glycemic control usually will be very motivated one, and they'll be able to achieve it fast. Because sometimes we are given a time that within 1 month, I'm going to go for an for an IVF. I want to be doing. So those are usually very motivated patients, and they start insulin and monitor and they control well. Yeah.
So absolutely. So I have not seen any lady not achieving a glycemic control. Even at an Institute of the Medical Sciences, ladies coming from the rural background and with limited resources used to take the regular insulin, NPH insulin multiple times, and used to have a good glycemic control, because they know that this is the thing they have to do and the timeline is there. Yeah. So, and we should definitely take this opportunity to improve their glycemic control and limit the complication, which you have told that the glycemic control is the most important thing. Regarding the complication, many a time we will not get the ideal situation like there will be no complication now as diabetes is increasing in younger population, as Dr. Neelam talked about. So obviously, when they plan for pregnancy, they have some sort of the complication like either the retinopathy or nephropathy. So how you optimize those complications in pregnancy, and at what level you have to you have talked about the allowing the conception, but many a time it's unplanned. So how to manage?
Yeah, so it's again depends upon the so most important factor is degree of glycemic control and what is the duration of diabetes and how long the glycemia has been poor. So all patients, like we work up for the diabetic complications like diabetic retinopathy, we have to get a baseline retina evaluation. And if there is some degree of retinopathy, we know that retinopathy will worsen during pregnancy. So if the patient has like something like severe NPDR and PDR, then it has to be treated prior to pregnancy or even CSMA, because many of these procedures will be actually not exactly contraindicated, but they are all category C, that they have not been tried in the pregnancy. So that has to be managed. If the patient has a very severe proliferative diabetic retinopathy, till the time that is settled, we should actually ask patient to avoid pregnancy, because that is likely to worsen, especially if the patient has hypertension, increase in the pregnancy, intravascular volume, that is all going to lead to worsening of retinopathy. Then second comes the nephropathy, which also usually if the patient has some degree of proteinuria, almost 30% will have some worsening of proteinuria. And also if the EGFR is on the lower side, that is going to deteriorate further during the pregnancy. So in those patients, we have to give them the guarded prognosis for the maternal, that maternal parameters are going to rearrange, and also the fetal abnormality, especially in patient who has a proteinuria, there may be IUG or preeclampsia, early pregnancy loss, that has to be explained. In those cases, glycemic control and the BP control has to be very important. Another important issue comes is how do we titrate the ACE inhibitors and ARBs in those, because most of the guidelines say that stop ACE inhibitors, ARBs. So that is going to further worsen their albuminuria. So some of the kidney guidelines do say that continue till the patient conceive, because many of these patients will have associated infertility, which they may not conceive also very fast. So it is very difficult to decide in those, and we have to have a risk versus benefit approach to these patients. And if the patient is long-standing diabetes with dyslipidemia, then or any other symptoms, then we have to do a complete cardiac evaluation, because that can be catastrophic during the second trimester.
Very good. So I think you have touched upon all the aspect of the management of the pre-existing diabetes during the pregnancy, and very, very practical manner. And I think this is what all we face. This is what we do see. Ideal situation we never do get in our day-to-day practice. So we have to be clearly visible. And all these aspects we discussed today are not often discussed and not often come across in presentation in most of the forum, and but relevant, very much relevant for day-to-day practice. Like Dr. Neelam talked about how important is the glycemic control for a lady. So a few years back, WHO has given a slogan that protect family, prevent diabetes, protect family. So diabetes should be prevention, and everything should start from the family, because the family is the smallest unit of the society. And for that, due care should be done for a lady with the diabetes, because if you are treating her well, obviously the whole family will also remain safe, and that will also percolate into the prevention of the diabetes in other family members, children, and the other relatives also. So thank you very much. I can't thank you more than this, because all of you have done a wonderful job. Dr. Amin, Dr. Neelam, Dr. Harman, and Dr. Parjit, who has to leave for a meeting right now. And I had some question from the question box, but all of those questions already been taken by you and during your presentation. And because of we have slightly overshooted from our expected time. So we will answer those chat questions to the audience directly. And thank you very much. And I also like to extend my thanks to our pharma partners, with Sanofi India as well as the lupin, the oral and the insulin division for supporting us for this academic activity, and also the DMC for awarding a certification credit for this presentation and the subsequent presentation on 18th. So all the audience, please do join us on 18th evening with some more topics and further discussion. Thank you. Good night, everyone.
Thank you. Thank you.
Thank you.